This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 1072, recorded on December 21st, 2023. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Yes, I'm back in New York. Hello, everyone.
Are you happy to be back?
It's mixed feelings. I love the time in Uganda. I love the time in Panama. Panama was a little special, right? Because my daughter joined me again, so that was exciting.
Mm-hmm.
It was a great trip, right? Uganda was fantastic. It's great to see all my friends there and my cattle. The Panama trip was really good this time. We went to one of the most remote islands. So 4.5 hours by boat, living in the village with the locals, sleeping in a hammock, using the facilities that the same ones they use.
Did you get a lot of bug bites, Daniel?
I tend not to get bitten by bugs for some reason.
Okay. What's on your tie this week?
So this is it's almost Christmassy, right?
Yeah.
But it's a virus, right? It's got that nice symmetry, and the artist says they think it's HIV, but it could be so many.
Okay.
Okay. But yeah, just a shout out to all the great folks that I had the opportunity to work with in Uganda, and then we had a bunch of medical students, Vincent, from University of Buffalo were down there with us in Panama. And really, really an impressive bunch. I wasn't sure they were medical students because they were like way too nice. So, they. All right, well, let's jump into it. A sad soul can kill you far quicker than a germ. That's by John Steinbeck. I'm not so sure how true that is, but I think it's a good conversation starter, as people start making decisions about what to do with regard to the holidays, right? It's something incredibly sad about the holidays where people were alone and isolated. And hopefully now with vaccines, with wise choices about air quality and ventilation, with jumping on treatment and testing, this can be hopefully a holiday season where people are not alone, and we can make some smart choices to allow people to be together and not have sad souls. All right, RSV, we're going to jump right into it with the article, The Annual Economic Burden of Respiratory Syncytial Virus in Adults in the United States, recently published in JID. Now, I think as physicians, we don't often think about disease in these terms, but public health folks are aware that disease can have tremendous impacts on the economy. I like to say it's hard to make one's country great when we are spending billions of dollars on vaccine preventable illnesses. But here is a cost of illness model where they develop an estimate of the annual societal burden of RSV in U.S. adults age 60 and over. Additional analyses were conducted to estimate the burden of hospitalized RSV in all adults aged 50 to 59, adults aged 18 to 49 with potential RSV risk factors. We read that U.S. adults aged 60 and over, the model estimated 4 million annual RSV cases, an annual economic burden of $6.6 billion. The RSV cases that were hospitalized contributed to 94% of direct medical costs. Additional analysis estimated $422 million in annual hospitalization costs among all adults aged 50 to 59. Among adults aged 18 to 49 with RSV risk factors, the annual per capita burden was highest among people with CHF, congestive heart failure, at over $51,000 per 1,000 people. And of note, this is just adults. Add in the children, and the numbers only get bigger.
Daniel, can you get a rapid antigen tests for RSV?
We actually have those. They have these. Well, you can't do it yourself, Vincent, but we keep these guarded. Actually, a lot of our urgent cares have these quad testing kits where you can get a flu A, flu B, RSV, and COVID all at the same time.
Nice.
So it's nice. It's nice for a few things. People sort of wonder, like, why do we need all these answers? Well, COVID, we've got treatment. Flu, we've got treatment. RSV, it's a big infection control issue. So, you find out that, somebody's got RSV and you can at least, give them recommendations. That Christmas party you're about to go to tonight, maybe you shouldn't go.
So it has to be ordered by a physician to get those tests.
Yeah, unfortunately, there was a brief period of time when those Lucira tests, you could actually do these at home. And like right when they went bankrupt, I got a bunch for $8 each. Yeah.
Oh, you're a sale shopper, are you?
I saw that. I was like, I jumped in. Now, unfortunately, I've lent them to other people. They're all gone. But yeah, some of the data we get is actually based upon not just PCR for RSV, but also some antigen detection results. And it looks like we might be peaking here with the RSV. So we'll see. But we're certainly way up there with RSV detections currently. So this is certainly RSV season. Remember, we've got vaccines, both active and passive. So we really want to use those tools. Influenza. I was joking with a patient today. I don't know how funny my patients think I am, but about, he had flu A, and I say, what happened? You opened the window and influenza? Okay, I thought that was funny. But anyway, he didn't laugh. The article, Recombinant or Standard Dose Influenza Vaccine in Adults Under 65 Years of Age, was recently published in the New England Journal of Medicine. Now, just a little background for folks. We now actually have specific recommendations for one type of flu vaccine over another in adults 65 and over, right? So we have a bunch of choices when it comes to flu shots. We've got the live attenuated, the stuff you spray up your nose, right? We've got the cell-based, the egg-based, the adjuvanted, the normal versus the high-dose flu vaccines. Quadrivalent recombinant influenza vaccines, for instance, contain 3 times the amount of hemagglutinin protein as our standard dose egg-based vaccines. And the recombinant formulation is not susceptible to antigenic drift during manufacturing. So here we have results from a cluster randomized observational study. Kaiser Permanente Northern California facilities routinely administered either a high-dose recombinant influenza vaccine, so flu block quadrivalent, or one of 2 standard dose influenza vaccines during the 2018, 2019, 2020 influenza seasons to adults 50 to 64, a little younger than that 65. That's the primary age group, and also 18 to 49 years of age. Each facility alternated weekly. That's how you got this clustering between the 2 vaccine formulations. The primary outcome was influenza A or B, confirmed by PCR. Secondary outcomes included influenza A, B, and influenza-related hospitalizations. The study population included, are you ready for this, 1,630,328 vaccinees between the ages of 18 and 64. 632,962 in the recombinant vaccine group, almost 1 million in the standard dose group. During this study period, 1,386 cases of PCR confirmed influenza were diagnosed in the recombinant vaccine group and 2,435 in the standard dose group. Among the participants who were 50 to 64, 559 participants, so 2 cases per 1,000, tested positive for influenza in the recombinant vaccine group, as compared with 2.34 cases per 1,000 in the standard dose group. So remember, we got more people getting that standard dose group, so that's why we're going to make that adjustment there. So they're giving us a relative vaccine effectiveness of 15.3%, not knocking your socks off. In the same age group, the relative vaccine effectiveness against influenza A was 15.7%. The recombinant vaccine was not significantly more protective against influenza-related hospitalization than the standard dose vaccines. So we're seeing a subtle little bit of difference here. favoring recombinant over standard dose, at least with regard to PCR-confirmed influenza, not necessarily seeing that effectiveness translated into less hospitalizations.
It's not clear to me what the outcome was here. They say PCR confirmed. Is that all, or was it symptomatic?
So you had two here, right? So these are folks that are actually, triggered. They weren't just screening, right? So these are folks that were going to go, with symptoms. So it's PCR confirmed influenza disease.
Okay.
Yeah. And then they're looking at the hospitalization rate, which was not different. So we're seeing subtle stuff. I sort of wonder when you see such subtle differences, how much, how far you want to go to the bank with this. But I will say, that gentleman that I saw today, he got his flu shot. And though he didn't like my first joke, he did resonate with my comment about, well, since you did get a flu vaccine this year, I expect this to be mild rather than wild. And he did say, I'm an older guy and I got COVID after being vaccinated and it was mild. So, sort of buying into this vaccine decreased ferocity of the infections.
As you said last week, Daniel, we need better flu vaccines.
Yeah, I think we do. All right, got another article. We're working on this theme, maternal vaccine effectiveness against influenza-associated hospitalizations and emergency department visits in infants, published in JAMA Pediatrics. These are the results of a prospective test-negative case control study using data from the new vaccine surveillance network from the 2016 to 2017 through 2019 to 2020 influenza seasons. Infants younger than 6 months with an ED visit or hospitalization for acute respiratory illness were included from 7 pediatric medical institutions in U.S. cities. Control infants with an influenza-negative molecular test were included for comparison. It's our test-negative design. Data were analyzed of 3,764 infants, 223 with the flu, 3,541 control. 53% were born to mothers who were vaccinated during pregnancy. Overall vaccine effectiveness in infants was 34%, 39% against influenza-associated hospitalizations, and 19% against ED visits. We see the best, so among infants younger than 3 months, effectiveness was 53%. Effectiveness was 52% among infants with mothers who were vaccinated during the 3rd trimester, and only 17% when mothers were vaccinated during the 1st or 2nd trimesters. All right, so just we should sort of start building a list of when mom's in that last trimester. We've got the RSV shot, the flu shot, the COVID shot, all these things we can do to protect that child for the first 6 months of life. And yes, we are full on in influenza season. We have lots of flu out there, so keep that in mind as we gather for the holidays. All right, COVID. New cases, 274,398. That is up. The average is going up. The number in hospital is going up. The number in ICU is going up. New deaths, 1,693. So the average is up over 100. So we are still sitting there over 200 deaths a day. And if we look at our wastewater, I feel like they changed the scale. Remember, it used to top out at 1,200. Well, now you can top out at 1,500. Just still rising there, particularly in the Northeast. Sort of see what happens in the Midwest. They've kind of hit that nice high level. And I'm hoping we get maps for COVID, the way we do for flu, where we get to kind of look and see where the flu is, and then when people travel. Got to compare them because right now, the flu activity is just going gangbusters in the South, in the West, and we'll look at that in a couple of weeks and anticipating that anywhere that's in the minimal low, we'll see the Christmas travel spread.
Well, Daniel, you can always use a positive test as an excuse not to have to go to some event.
Not that I would ever do that, Vincent.
No, I'm sure you wouldn't do that. No.
All right. The article, Risk of Severe Maternal Morbidity Associated with SARS-CoV-2 Infection During Pregnancy, right? So we talk a lot about what moms can do to protect their babies. But what about moms protecting themselves? And this is an article recently published in Open Forum Infectious Disease. We have talked repeatedly about the fact that SARS-CoV-2 infection during pregnancy is not great for mom. Definitely not great for the neonates. So here are the results from a national cohort study of 93,624 deliveries that occurred between 11 March 2020 and 1 July 2021 using medical claims information from Optum Labs, data warehouse. A little plug for Optum there. Do I have that little thing? Oh, it's in this side of the shirt. Okay. They now sign my check, so I got to be nice to them if I want that to continue. But SARS-CoV-2 infection was identified from diagnostic and laboratory testing claims records. 4.8% of deliveries had a record of SARS-CoV-2 infection. 27% less than 7 days before delivery. 13.5% within 7 to 30 days delivery, and then about 60%, so 59.5% earlier in the pregnancy. Compared to uninfected pregnancies, the adjusted risk of severe maternal morbidity was 2.2 times higher among those infected less than 7 days before delivery, 1.66 times higher for those in that 7 to 30. The highest risks were observed for adult respiratory distress syndrome, and that was an adjusted relative risk of 13.24. And interesting, acute renal failure was almost 4 adjusted relative risk. So all the limitations inherent in the study design, right? We're looking at, labs, we're looking at medical claims data, et cetera. So, but just not great to get SARS-CoV-2 when you're pregnant. Okay, moving on to testing. I'm hoping people are thinking about doing this. I think poor Barnaby got something stuck up his nose this morning because the in-laws were coming, and we definitely don't want to make my in-laws sick. So just a reminder, right, that article we talked about last time, COVID-19 rapid antigen tests with self-collected versus healthcare worker collected nasal and throat swab specimens. Use the tests in the way that they were designed, in the way that they were validated. I guess unless you're trying to get out of that Christmas party and then drink yourself a soda and rub it on your tongue. All right.
Daniel, can I ask, if Barnaby tested positive, what would you do? Lock him in his room or tell your parents not to come?
Well, first off, we would call the in-laws and say, turn around.
Okay.
Then I would lock Barnaby in the room. Actually, I'm working over this holiday weekend, so for me, the exposure would be low. So, All right, ventilation, transmission. We'll be talking a little bit more about this next week, right before the New Year's parties. But leave those fans on, crack those windows. We'll talk a little bit about the relative risk in different situations. But as we've talked, it's time, it's distance, it's poor air quality. So this is something you breathe in. I still want people washing their hands, but all right. Now, unfortunately, you test positive. You're a high-risk individual. What do you do? Number one, Paxlovid. But when do you start? Do you kind of wait around, Vincent, see how people do, wait around, let that immune system kick in?
No, you start right away.
All right. Well, let's talk about some science. So we got the article, Optimal Timing of Nirmatrelvir, Ritonavir Treatment After COVID-19 Symptom Onset or Diagnosis, a Target Trial Emulation, recently published in the August journal Nature Communications. So here, these investigators performed a 2 territory-wide retrospective cohort analysis using the Target Trial Emulation approach to examine the effect of timing of Paxlovid initiation on the incidence of all-cause mortality, all-cause hospitalization, and viral burden rebound among all adults aged 18 and over, looking at patients that had initiated Paxlovid in the Hong Kong Special Administrative Region, China, between the 16th of March 2022, and that's when Paxlovid first became available, and the 15th of January 2023. So during the study period, COVID-19 infections in Hong Kong were predominantly caused by Omicron and its subvariants. So the authors are going to talk a little bit about VBR, viral burden rebound. The authors point out that a number of case reports and studies have reported symptom recurrence or viral burden rebound after initial recovery upon completing a standard 5-day course of Paxlovid. I will mention that also happens if you don't take it, so I'm not sure how you call that Paxlovid rebound. But anyway, it has been hypothesized that initiating the Paxlovid too early after symptom onset may in some cases be associated with the VBR. Thus prompting some folks to say, why don't you just sort of wait around for a while before you start that life-saving medication? Well, due to early viral suppression of viral replication by Paxlovid, the idea is the host adaptive immune system may not have sufficient stimuli and time to develop. Well, okay, let's see what happens here. So early initiation was defined as a prescription of Paxlovid within 1 day from the date of COVID-19 diagnosis or first symptom onset. Late initiation was defined as prescription on or beyond day 2. Index date was defined as that of either the SARS-CoV-2 infection diagnosis or symptom onset, whichever occurred first. A total of 87,070 Paxlovid users who had confirmed diagnoses of SARS-CoV-2 infection were included in the analysis. Early initiation of Paxlovid within 1 day was associated with a significantly lower risk of 28-day all-cause mortality or hospitalization, adjusted relative risk of 1.5, so about a 33% reduction versus late initiation. A significantly lower risk was also observed if you got the Paxlovid initiated within 2 days versus 3 or more days, and that's about a 30% reduction within 3 versus 4. So you just keep seeing this trend. Their data suggests that early initiation of Paxlovid may be associated with an elevated risk of that VBR, but they do comment. They say that without much certainty. There was a paucity of these VBR events, wide confidence intervals, but clearly early treatment was associated with better patient outcomes. All right, number 2, remdesivir, if you can get it. Number 3, molnupiravir. Number 4, convalescent plasma in certain circumstances. Isolation for the infected. Part B also almost was isolated for days. And let's not do those harmful and useful things. I'm just always shocked at the amount of antibiotics that get thrown at people. I just had a patient today. Yesterday got diagnosed with COVID. We had the whole discussion. We started with Paxlovid. I get a message from the office that, my patient now has a sore throat and he would like you to send in a script for antibiotics. Bam. Okay. All right. Week 2, the cytokine storm week. Steroids only at the right time in the right patient at the right dose. This is after that first week. Oxygen saturation is less than 94%. We have anticoagulation guidelines, pulmonary support, remdesivir still in the first 10 days, immune modulation perhaps with tocilizumab. And now we will move into COVID, the late phase, past long COVID. Really still seeing a significant number of folks suffering from this. And this, I included this article sort of prompted a comment that my wife made about maybe we just see a lot of long COVID versus long flu because we're just looking. I said, no, actually, I think it's more actually. So let's throw some science at this. The article, Long-Term Outcomes Following Hospital Admission for COVID-19 versus Seasonal Influenza, a cohort study published in The Lancet Infectious Diseases. This is a cohort study where the authors use the healthcare databases of the U.S. Department of Veterans Affairs. This turned out to be a great resource. They analyzed data from 81,280 participants admitted to hospital for COVID-19 between March 1, 2020, June 30, 2022, and 10,985 participants admitted to hospital for seasonal influenza between October 1, 2015 and February 28, 2019. Participants were followed for up to 18 months to comparatively evaluate risks and burdens of deaths, a pre-specified set of 94 individual health outcomes, 10 organ systems, overall burden across all organ systems, readmissions, admissions to ICU. There's a lot in here, so it's worth reading. Over 18 months of follow-up compared to seasonal influenza, the COVID-19 group had an increased risk of death, hazard ratio of 1.51. And this is really, I think, what is shocking. An excess death rate of 8.62 per 100 persons in the COVID group versus the influenza group. Just really shocking, right? People always ask, oh, what's the case fatality rate for COVID? And they quote sort of in the 2, 3, 4%. This is an extra 8.6% of these folks dying versus folks that ended up in the hospital with flu over just 18 months. Compared to seasonal flu, COVID-19 also had increased risk of hospital readmission, excess rate of 20.5 per 100 persons, and admission to ICU, excess rate of 9.23 per 100 persons.
But Daniel, this is not long COVID, right? Dying is not long COVID.
It's worse than long COVID, perhaps, depending who you talk to.
But we have no information of whether they had long COVID up until the time of death, right?
Yeah, so this is, well, I say this, there's this push, and I sort of agree with this push of talking about post-acute sequelae of COVID, right? And long COVID is really just a subset of the bad things that can happen to you.
Okay.
So, I'm glad you bring this up because, you get COVID, and there was a lot of people who would just sort of, maybe it's dismissive, I'm not sure the right word, but they're like, oh, you 2 weeks, you either live, you die, and then you move forward. But that's not true. Some people develop diabetes, they develop heart failure, they develop heart arrhythmias, they die, they end up readmitted, they end up unable to, care for their family or return to the office. So post-acute sequelae of COVID is really more than just, this chronic fatigue, ME/CFS type syndrome. So on that note, other things that can happen. This is post-acute sequelae of COVID. That's not actually long COVID. The article Risk of Arrhythmias Following COVID-19, a nationwide self-controlled case series and matched cohort study published in European Heart Journal Open. This study was based on national register data on all individuals in Sweden who tested positive for SARS-CoV-2 between 1st of February 2020 and 25 May 2021. The outcome was incident cardiac arrhythmias, atrial arrhythmias, paroxysmal supraventricular tachycardias, bradyarrhythmias, and ventricular arrhythmias. These results are from a self-controlled case series study and a matched cohort study performed to determine the risk for arrhythmia event following COVID-19. Large numbers here, a total of 1,057,174 exposed individuals were included in the study, as well as 4,074,844 matched unexposed individuals. The incidence rate of atrial tachycardias, paroxysmal supraventricular tachycardias, and bradyarrhythmias was significantly increased up to 60, 180, and 14 days after COVID, respectively. In the matched cohort, the risk ratio during the first 30 days was 12.28, 5.26, and then 3.36, respectively, for the three outcomes. The risks were generally higher in older individuals, unvaccinated individuals, and individuals with more severe COVID-19. All right, and I'm going to wrap it up there, Vincent. I'm going to keep this short for the holiday weekend. I already started working on the one that's going to fall after Christmas, so we got a lot coming up. But I just want to remind everyone, no one is safe until everyone is safe. I do want everyone to pause the recording right here, go to parasiteswithoutborders.com and click on that large donate button. Even a small amount helps. We're right in the middle of our Microbe TV fundraiser, which for November, December, and January, we're almost done. Only a month to go after this. We double your donations up to potential maximum donation of $20,000 to support Microbe TV.
It's time for your questions for Daniel. You can send yours to daniel@microbe.tv. Len writes, "Hi, I'm a long-term listener and truly appreciate the objective knowledge you share with humanity. That said, this is a burning question of mine and likely many other curious minds out there. When using a nasodilator like Afrin to decongest your nose, one usually only needs it for a few days at most, which is what the manufacturer recommends as well. So we are left with a nearly full container to throw away. Given we become immune to the virus that causes our common cold or COVID-specific variant or whatever, can we wipe the applicator with alcohol and safely reuse it up to its expiration date? Really looking forward to your insight on this.
So that's actually what I do. Because that is right. You get containers of afferents sitting around. You only want to use 3 days because if you go past 5, you get this horrible rebound, which unfortunately I've seen. So yeah, I usually just wipe them off with alcohol, let it air dry, put it back in the cabinet. Yeah.
Okay, there you go. Volker writes, I'm 49 years old, good health. I run 100 kilometers each month. I've been vaccinated 3 times and had COVID-19 at least once almost 2 years ago. Last Saturday, I started to notice some symptoms and performed a SARS-CoV-2 test on Monday morning, which returned positive result. Since you recently took Paxlovid, despite having no comorbidities or risk factors that I am aware of as a very long-term listener of TWiV, I requested my general practitioner to prescribe it to me. He did so, albeit reluctantly, stating that I would not benefit from it. Could you please explain how I might benefit from Paxlovid? Are we talking about a shorter recovery time, milder symptoms, lower viral load, reduced risk of long COVID? Could you also provide links to relevant studies that I could forward to my GP? Generally, who should take Paxlovid in the absence of risk factors?
Okay. Now, this is a great question because, should everyone get Paxlovid? That's sort of the sort of thing out there. So I am over the age of 50. Hopefully I look younger than stated age. That's what you like to see in your history. You never want to hear it appears older than stated age. But so yes, I am over the age of 50. No, otherwise, actually, I'm healthy. Like, no blood pressure, no other issues. I keep my BMI right at 25 plus, just, so I've got that as another risk factor to allow me access. I'm joking. But the most compelling evidence for Paxlovid and really the evidence-based recommendation there is for folks that are high risk at progression to severe disease, ending up in the hospital, not surviving. So that group, it's a no-brainer. It's really pretty clear. There is some growing evidence that you may actually reduce your risk of long COVID in adults. Actually, there was some recent data in children as well. So sort of a suggestion there, not just the acute, but as we keep talking about, the post-acute sequelae. There's data that we've talked about where there may actually be a quicker symptom resolution. But no, the real big push for Paxlovid is for the higher risk individuals, who are going to progress, who are going to end up with severe disease.
Lauren writes, is there any news regarding updating antigen tests with more accurate versions? I imagine the commercial value of developing better antigen tests is low as demand has probably dropped. But they're such an important tool for those of us who are still trying to avoid COVID. It would be incredible to be able to depend on them a bit more and be able to gather more safely via testing friends, family, caretakers, colleagues, etc.
Yeah, I think this is an excellent comment. Remember, much of what happens in the United States is driven by market pressures, the ability to make a profit when you invest into new technology. When I talked about that article last week, right, where people were, somehow getting these Q-tips into the back of their throat and swabbing the palatine tonsils and the posterior pharynx, not the tongue, not the sides of the cheek. And there was a discussion about, the fact that, manufacturers could upgrade their kits and then spend millions of dollars on validating these modified tests. And then I do remember, like, a bunch of years ago, there was somebody who was on our show who had a desk full of these, like, saliva tests that he could make for $1 a pop. Forget who that was at the moment. Those seem to have never come to the market. Don't laugh, Vincent. But no, I think that's what we're getting into. There's sort of a loss of reward here. I don't really know how much people are testing and how much of a market really is there for people coming up with newer tests. So, I mean, the current tests we have are still reasonable. Particularly if you do serial testing, they're still an effective tool.
Alan writes, with respect to rapid tests, is there any meaning to them after one has tested positive? I have patients and family who have COVID who monitor the redness of their positive test line. Does a lighter color mean anything? Does a negative test after 5 or 6 days mean that you don't have to mask till day 10? Is there magic in 2 negative days in a row? If that were days 5 and 6, would it really mean you are not contagious? By listen to what he says, Daniel. By listening to TWiV, notwithstanding being a psychiatrist, people come to me for advice on COVID.
I like that. That's great. It is tough, right? Because there's even this I don't know if it's still up there on their website, but this whole test out, protocol from the CDC about, if you get 2 negative tests and it's, 5 days and your symptoms are gone. I'm not really sure I'm convinced that repeated testing does anything other than help you develop some sort of a neuroses, and that probably drives your business. So, I don't want to stop that from, but no, this is a test that tells you, do I have COVID or not? And then as we've talked about, it's a little bit suspect how good those tests, really are at all for judging whether or not you're contagious. I mean, lots of little, catchy, enough to detect enough to transmit or infect or whatever people want to say. But it's not really clear to me that after you get a positive test that you need to keep doing any of those tests. We've talked about the lack of correlation with culture positivity, nothing compelling really with regard to those ongoing positive antigen tests and transmission tracing. So I usually tell people once you're done, save those tests for the future.
And Nicole writes, many doctors remain unsure how to answer this question, so I'm hoping to get your expertise. Are you universally recommending RSV vaccination for adults over 60, even those without cardiopulmonary or other comorbidities or immunocompromise, strictly on the basis of age? The CDC website highlights the small neurologic signal seen in the trials, and therefore some have only been recommending this vaccine to the highest risk patients, defined by comorbidities or perhaps extreme of age, not solely based on age over 60. Would you recommend it for everyone over 60, despite the small neurologic signal, which may or may not be related to the vaccine? And if not, would your answer change for even older adults, i.e. over 70, but without significant comorbidities or immunocompromise?
Yeah, so this is a great question. I like this, and and I want to avoid eminence-based pronouncements. So I'm going to basically share what do we know and where are we. So in the spring, right, May 2023, these vaccines became available. They got approved, and in May, the initial recommendation was shared decision making. This sort of questionable signal was shared with the public and with everyone, and that was supposed to be part of your decision making. We have now seen millions of doses. We are not hearing of any concerns. So what I'm going to say is a lot of us, based upon the science, based upon what I will say is post-marketing surveillance, so millions of doses being given out, we are not seeing concerning neurological signals here. So here we are, peak of the RSV season, lots of folks ending up in the hospital, thousands of people dying, right? We'll get a total at the end of this season, but it's usually going to be in that 10 to 20,000 range for adults. And also, you get it, you transmit it, et cetera. So, most of us based on the science, a lot of us based on the science are now sort of moving from that initial May shared decision making to a universal recommendation of folks 60 and over, but based upon the science, not just based upon my eminence.
That's TWiV, weekly clinical updates with Let me start over again. The eminence thing. I'm trying to work in with eminence, Dr. Daniel Griffin. That's TWiV, weekly clinical update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you. And everyone, be safe.
His Eminence.
His Eminence.